السلام عليكم. For those who are joining us online, just let me know if you guys can hear me or not. Exactly. Okay, we'll go ahead and get started. My name is Rashid Al-Boadi. Thank you all for joining us. We're excited to have you all on board. Just to give you a bit of background about the Jeddah Cardiology Club, it was started as an initiative from the National Heart Center with Dr. Adil Bash. I was chairing it and co-chaired by Dr. Salim Asiri. It has been going on for over a year, and it's been a great success to have the people locally join and exchange ideas and cases. We are excited and delighted to launch a newer version of this. We are joined by the SASIS group, and now we're going to actually have a virtual option too. For people who are local, we prefer to have them still here coming physically, but for the people who are not local, have the opportunity to join us online. This will be mostly just discussing cases. There wouldn't be any literature review. We all know that we learn a lot from cases, whether it's complication, tough cases, difficult dilemmas. So we will go ahead and get started with our first case. Just to give you a bit of the newer version, we have Dr. Mu'tasim Tarabutsi, who's going to be also co-chairing the newer version of this, along with SASI's contribution. So we have two exciting cases. We'll start with the first case with Dr. Mu'tasim Tarabutsi, and then we'll follow by Dr. Khalid Tamam.
Shukran, Rasha. Thank you all for joining us tonight, despite all commitments, despite all our commitments. I'd like to start with a case that really gave me a lot of trouble while I was working, and I faced a lot of difficult decision, and I didn't know what to do, to be honest. I thought it was a very tough case. Please stop anytime, ask questions if you have any ideas. That's the whole purpose of the Sanju Club, is just to try to learn from each other and see where we can improve in our practice to serve our patients in the community. So I'll start with a brief history. This is a 52-year-old gentleman, no prior medical illness. He also has no known risk factors of coronary disease. He's actually originally from India, and he's a truck driver who works in Dubai. And he was driving from Dubai with his truck to Medina. And 3.5 hours before getting into Medina, he started having some chest pain. And his truck stopped in front of our hospital. And they got him into the hospital. So his initial examination, nothing really concerning except that he was anxious, he was living in distress. His heart examination, he had no murmurs, and his lung exam was clear. So immediately, so we got some labs on him. Mainly, he had a slightly elevated white count. His LDL was also elevated. And other than that, his troponin was also elevated. Cutoff was around 14 for negative. This is consistent with his history and the time of his presentation, which is around almost 4 hours. So this is his ECG. So until now, really, there's nothing going on. It sounds like a very straightforward ST elevation MI. The cath lab got activated, and we immediately took him to the cath lab. So, sorry. So this is his first picture. Again, nothing surprising. His distal RCA is occluded. The whole RCA vessel is just, you can see the mid segment is ectatic, dilated. His left coronary system also had no significant disease, just mild disease all over left main, left circ, and even in the LAD, you can see on the next picture. However, the LAD had some slightly ectatic mid segment. I don't know if you guys can see here, but there's some, sorry for the, I think we converted the file here. This segment here had some ectatic segment. So, I will leave, I'll ask you guys, usually for STEMIs, do you guys usually go with non-culprit first? Do you guys use with single catheter? I don't know what everyone's practice in these kind of situations in STEMIs.
Oh, me? Okay. If it's anterior STEMI, I go culprit first.
You go culprit.
I go culprit first. I don't even waste my
You don't
time
waste your time, right?
on the right. If it's an inferior STEMI, I don't do guesswork. I look at the right. If that's clean, then I go for the guide on the left.
And that's the issue. Like a lot of times they say inferior, they look at the ECG and they say,
Yeah.
oh, this is to the ABF, oh, it's a circ, it's a height, and then you open the RCA and after you spend 2.5 hours, then oops, the circ is the one that's the culprit. I don't know why, what's your thoughts? Well, I think is
sorry, Allah was technical.
لا لا
I will echo what Waqar said. Just go ahead.
with a guide for interior
Yeah.
scans.
And encourage the people who are online, if they have
Yeah.
questions and want to.
Yeah, any questions, yeah, the whole purpose is to learn, to be honest.
And,
You can ask the audience.
For the people who are joining through Zoom, if you guys have any comments or any questions, please let me know and we can put the mic on for you guys.
For me, even like if it's an interior, well, I just go with the GF or just see if I have a CTO on the eye, just to anticipate I'm going to run into problems, or if I should call for backup support or hemodynamic support. But any thoughts about the approach? Seems like straightforward, just take a guide wire for now, right? Yeah. One of my old attendees, like we asked him, so what do we do in this case? He would say, wire balloon and stent, So anyways, I take my my JR4 guide, the usual workhorse wire, BMW, and unfortunately, I could not take my wire down into that PDA. You can see clearly that the wire just goes into the AV loop, into that PL or the continuation of the RCA. And you can see that the whole vessel is just full of thrombus. And I just cannot see where my PDA is. I don't see any of my PLBs. But I stored some flow with that wire going in. You can see some late filling. And again, I'm not sure which one is the PDA, which one is the PLB.
Did you do any ballooning or this was just?
This is just
wire?
what was by my wire. So here I take I think like a 225 balloon, maybe 225/12, and basically just trying to move it through that thrombus, to try to really see what I'm dealing with, where are the vessels. And then I just take it up to a very slow inflation. You know, I was dealing with a lot of thrombus, and my concern was that, you know, I would have no flow or something along those lines due to that extensive thrombus. I'll let this
Is
just.
it not dry aspiration?
Well, I haven't yet. This is just trying to figure out really what I'm dealing with, and I just wanted to balloon to see where things are. But would you start with aspiration up front in this kind of case?
Yeah, if I don't get a good flow, I will, yes.
Up front, right?
Yeah.
Not even before you put the balloon, you just take the aspiration catheter.
Unless it doesn't go.
In this.
Was underlying anesthesia, I see the arteries static, blocks apart, so I expect to be hypertension.
Sure, sure.
So I can start with aspiration from beginning. But if there's some cases we're facing difficult even in crossing with the aspiration catheter.
Yes.
So we can use the balloon as a
Balloon is it. So anyways, got some flow back as you can see, but again, I cannot tell where that PDA is coming on, where is the takeoff? And I'm not sure if it's a PDA or if it's a PLB.
Did you
Right.
try to use another wire? PDA?
Yes, so after I ballooned, just took a picture and still, you can kind of have a glimpse like where is it coming off, but still you don't see the ostium clearly of both vessels, either the PL or the PDA. So you can see here slightly there's something coming off here and something coming off here. So now the question, should you continue ballooning or aspiration? I think what was talking about the thrombectomy, and at this stage I decided to go with manual aspiration. We didn't have the number catheter yet in the hospital. This case was done back in March, so it's still not yet on our shelf, and I don't think it's still on. Our radiologists do have it, but we don't right now. So I started with my first run, and I would like to ask you guys, like, usually how many runs do you guys do when you use the manual aspiration? How many runs? I don't think there's a set defined number for how many aspiration to get excellent results. Like even on the trials, if you look at the trials, I don't think they mentioned anything about how many times they did the aspiration. Okay. How many runs? Case by case.
But in this situation, after I'm doing a low like this case, and still things you want to go, I can inject intracoronary distal, intracoronary medication, especially the light, aggressively. It can be a little bit widen the microvasculature and improve the flow in many cases.
Sure, sure.
I mean, have you considered in this case, giving intracoronary glycoprotein inhibitor, or sometimes, I know some people, they try sometimes to give thrombolytics intracoronary.
Sure.
Have you tried it?
I haven't tried it. At this stage, I haven't tried anything. I was just really focusing on trying to get the vessels open. However, I called for Acostat to be started, but I didn't give anything intracoronary at this stage. So I did 2 runs, I aspirated, and then took another injection, and now you can see a vessel starting to show up. And again, I wasn't sure which vessel is this, but I thought it could be a PDA, I'm not 100% sure. So I'll just keep it running so people can see it online. If you want me to go back to any images, just let me know, it says for the sake of time. So what Salim was asking, I took a second wire, and luckily at this stage I knew exactly where to push my wire, and luckily I was in the true vessel. I took my aspiration catheter, I did a couple of runs, and then and this is my image. So now once I aspirate, I started seeing more of a vessel. And now I can start to see really where that PDA is coming off. And
It was distalized to.
yes, yes. So I pulled my wire and put it down to the PDA. I was focused really mainly on opening that PDA, and I didn't want to give up my wire position to ABO. So again, I just took my used balloon, tried to just move it across that clot, try to break stuff. It was already inflated from the prior time, so just try to move it back and forth. And then I inflated that really low atmosphere to see if I can restore flow or if I can get flow into that PDA. Here's my next image. Again, flow wasn't great in that PDA. You can see that PL branch is occluded. Again, I took another balloon and tried to balloon, and then after that, you'll see that I actually restored flow to that PDA with a TMD flow, and with some distal localization into that distal vessel. Now I took my aspiration catheter again after I tried to break all that thrombus off with a balloon. I did a couple of aspirations here. And this is my picture. And now you start seeing that PDA. And I apologize for the quality of the images because I actually, when I do a lot of my cases, I use flow safe. I don't use settings. I try to minimize all my settings for stead boost and all that stuff just to minimize the radiation exposure. Again, another aspiration on. Then I pulled my wire to try to see, how things look. So I can't really see a dissection or anything. I just see that ectatic segment into the distal RCA that still has a thrombus in it. But the whole PDA ostium seems like when the proximal PDA looks fine. But the distal PDA there's some clot that showered distally. So but overall the PDA looks good. Now I focus my attention on trying to open that PL branch, and I tried to tubal a couple of inflations to restore flow. And you can see slightly that I started getting flow back into that PDA.
Yeah.
Again, I took another aspiration on at that place as well. But this is almost 2 hours into this case. It was midnight when I started.
So did you try to use like intracoronary, like nitroglyceride?
Not at this stage yet. And I was focusing on just to try to aspirate, and the issue was all thrombus and trying to get rid of all that thrombus, debulk the vessel from all that thrombus.
How was the ECG and the patient just pain at this stage?
At this time, now he started to settle down. His ECG started to improve, and his pain is improving now at this stage.
So basically, we are dealing with ectatic vessels with a large burden of clots.
And I almost did 7 or 8 tons of manual aspiration, almost.
Is there bulk thrombus comes out?
I will show you actually the amount of thrombus that I got out of this case. And really, it was a very challenging case because I didn't know what to do next. Like I stood after the patient improved, I had Timothy flow, and I looked and I thought, what do I do? Where do I start? Where do I stop? Where do I stand? Should I stand? Should I not stand? And that's where my issue was. And I thought this case was, a good case to present because
I think no matter what you do, you're always gonna have a distal cutoff. The
yes,
question is, at what level distal cutoff you would take? So you'll
Yes.
try as much as you can to improve the
Absolutely.
flow. and then leave them on Agrostat and.
So what do you do, Waqar, at this stage? Muslim,
I'll stop there.
eight time of aspiration. Honestly, I wouldn't go on Muslim 8 times. Like 3, 4 times, and then I will change another strategy. So what do you think, Waqar?
I think I would just now try to get as much flow as I can and then use my pharmacology to
Yes.
improve
Okay.
flow.
And I was gonna call him in the middle of the night when she said it was 2 o'clock in the morning. I don't think she wanted to my phone call. But yeah, at this stage, this is the question would be, again, I didn't know what to do, and thinking, and like you guys were saying, what should I do next? Just continue with lumpectomy? Should I keep him on heparin after the intervention of the procedure? 2-BPA inhibitors, intracorneal lytic. I think there's no wrong or right answer, or what's going to be the long-term strategy for treating this patient. But one thing I did, I thought, at least I want to know what's going on into that vessel. Should I stent somewhere or just go? But answering your question, how much is too much of aspiration? And this is the first time. This is the second run.
Oh my God.
Third run. Fourth run. Fifth. There's a lot of clots. That's the problem. When do you stop? There's no cutoff for. But the most important thing is really to clear your guide, aspirate after every, and that's what took so much time. Every time we took the export catheter out, you have to flush, you have to bleed back, it took a long time. It's like now we're talking about 2 a.m. in the morning.
So do you think if something like Penumbra, Russia will make a difference here? What is the new Penumbra or CAT?
Yes. Yeah. Cataracts, the catheter.
So if it was proximal, maybe, but I think at this point, we're left with very distal clots. So he was able to open the PD up until the distal, the POV could flow up until mid. So in the beginning, yes, maybe less than 8 runs, it would have been 1 or 2. But as I said earlier, I think you're gonna be left off with distal cutoff, but at what
And this is my final result here. And I took a few more images and then I waited a couple of minutes and then took my other just to see if there's any acute vessel failure after my work and then if I need to go do some stuff. At this stage, the patient was really asymptomatic. His ST elevation started to prove, and hemodynamically he was stable. So I left to stop. We got him off the table, sent him to the ICU. And this is his ECG, just by doing manual thrombectomy, this is his ECG almost normalized. You know, there's some changes in the and AVF, but this is his echo the next day. He had a normal EF and no really significant wall motion abnormalities in the inferior leads.
What's your plan at this stage to bring him later, relook again?
So unfortunately, and he's a truck driver from Dubai who luckily landed in our cath lab. But we kept him for maybe 3 or maybe 4 days. He was discharged, pain-free, asymptomatic, he had no complication. We started him on Xarelto in addition to Plavix. And I don't know, what would you guys would do? Would you keep him on a NOAC or would you just keep him on DAP? That's also the question that we always debate with these kind of patients. Now, just for the record, he had no shunt on the echo. You know, he came for a very long trip from Dubai. He was driving a truck, so you know the possibility this guy did have a DVT, did he have a shunt, did he have a PFO or something? He had an MI due to that, but he had nothing on the echo.
After wiring Baqara and he discovered that there is ectasia and probably large burden of clot there, would you start agrostat up front?
We did, yeah.
Usually do. Usually do.
And as usual, you will keep it 16, 18.
We kept it actually for more than 24 hours on agrostat as well. We went to ADL, is this bleeding was okay, so we just, you know what, let's just push it and see if we can.
Actually, this is a very interesting case. And in summary, ectatic vessels, large burden, you did everything that we can do. Aspiration, pharmacological, and your IBIS prove there is no occlusion in the and the other also the angiogram of the left side, there is slow flow in general. So what I will do with this patient, for sure, indefinitely he need aspirin. Regarding the Plavix, I will give it for a longer period. You need aggressive risk modification, stop smoking, stop other thing if he's taking other thing that you'll never know based on this quick presentation. Maybe he need counseling, health, you know, like educator sit with him, and that's all what we can do. I let him go back to Dubai.
Yeah, he went. So that's why we kept him for a longer day because he had to go back to
But
Dubai.
I would have kept him on day 4 before he.
So that's the question we debate. Like, should I cat him or just he's asymptomatic? He looks good. He had no whole bunch of so I find like, should I cat him or not?
There is no evidence, but I always cap patients on day 4 when I've kept them on heparin, enoxaparin, and when there is a lot of clot burden.
You would in the absence of symptoms and
In the
normalization of the echo. Okay.
So that's with the IBIS. By doing IBIS, after thrombectomy, did you find any significant plaques that people?
What it is, of course, it's diffuse disease, diffuse plaque in the whole vessel, plus that ectasia in the whole distal segment. So it's a very large vessel, it's like four something at least of EL. But yeah, there was diffuse plaque, and that's why I wasn't sure where to start, where to end, where to start stenting. So I figured, you know, this stenting is not an option for this guy.
Any other plaque rupture that you can see?
I couldn't see it on the IBIS. Again, we're using the volcano, so it's not really high definition, you cannot see. And we just got the OCT, so we didn't have OCT at that time. But otherwise, it would be a nice case for an OCT where you can see small dissection or something.
When you enter with STEMI2 flow, one flow, you inject medication intracoronary. guide tester or through special.
If I'm gonna inject, I'll probably just take a micro catheter and just push it distally, the distal bed, better than to push it to the guide.
Yeah, because we have in our center Amicas, which is actually the fusion catheter. We inject, in case like this case, we into STEMI2 at one flow. We inject all medication, the bride, the nitrates, agrostat, all distal intercoronary, and good give impressive results.
And you can take even a guide extension and just put it distal in to save the time.
I export itself.
Because you can use absolutely.
Export use it already.
You can use absolutely. Since we have it already there.
Just have a question from the online. Just read out the question.
Can you raise your voice?
Hey.
So we have a question from one of the Zoom attendees. It's an ectatic and large thrombus. Any vasculitis workup, or would you do a relook in a couple of days?
No, we didn't do any vasculitis workup. And, you know, we didn't look at back just because I thought, you know.
And
Is
we had
asymptomatic.
this debate on relook. Some of the people in the audience mentioned that they would do routinely if they thought they
Routinely.
had 2B3A. But according to you, he didn't want to do it because he was
He was
asymptomatic.
asymptomatic, like you saw, the echo was normal, and the ECG also normalized, he was asymptomatic. We thought, you know, doing a relook is just, it's not gonna change the management of this patient.
And where, how about Zeralto? You started Zeralto.
That's what the whole debate, you know, the ectatic vessel, a lot of thrombus, and that's, I don't think it's still an area that not a lot of people will, yeah, you know, one will, I think 50% will tell you do it, 50 will tell you probably don't do it. I'm not sure.
Let's take a vote. Let's take
Yeah,
a vote in the room.
That's what I'm saying, I don't know.
Would you give the
Xarelto, this high thrombus burden, ectasia, slow flow.
I was in the same situation, but you know, the ectasia was really big to the point that I can't put a stance. I mean, there's no
Yeah.
size that I can put. I did not discharge with Xarelto. I mean, I just discharged on aspirin and Prolenta. And I didn't put a stent. So, you know, I would not discharge on Xarelto unless there's, you know, good reason for that. That's the only maybe.
Point is well taken, but actually, I debated, what should I do for this patient? He actually got the Lenta, he got it to the then we switched it to Plavix because we said,
Exactly.
we're gonna put him on Xarelto, but yeah, the thought, you know, there's no any evidence for using Xarelto with these patients, but
Specifically for ectasia, no, but for now coronary disease, Xarelto 2.5 milligrams is approved. Specifically for coronary disease, yeah,
With a higher bleeding risk,
yeah.
sure, yes,
but here you're dropping the aspirin. so-
dropping the aspirin, that's why
Tropic
it's-
aspirin, he's young, he is not bleeding risk factor.
he's a young guy, like we said, he's in the early 50s, so, you know, at least for a year, just to.
I don't know also if it's only me, because we know the thrombectomy is for bailout, but since I came here, I've used it a lot, you know, when I was in our fellowship, actually, we did it with the so we didn't do a lot of thrombectomy, but here, yeah, every other case.
Is-
You know, you balloon and you still need to use something to get that clot out, so I mean, it's unfortunately that that's what we face.
So who will go with dual antiplatelet? Who will go with the single, like antiplatelet plus anticoagulation?
That's the question.
First.
So question, who, like even, is there a poll out of the Zoom, or we can just ask the,
No,
who would use DAP versus NOAC and Plavix? Who would use DAP?
Oh, it's gonna be one.
Ticagrelor and aspirin. And who would use Xarelto and Plavix?
I would do it.
Yeah, no, yeah, 60-40 maybe.
No, not 60, 80-20.
Ah, yeah, 70-30, I'll meet you in the middle. Deal?
We can wrap up.
It's probably 6 months or a year, but then we can, unfortunately, the patient is not here, he's in Dubai. That's the unfortunate part, passing kid. And we played it say, and.
So I'm assuming also you did full hematological study to like, would you do like the hypercoagulated state for him?
So I'm not sure, like in this state, how accurate the would be these
We checked
studies.
for PFO and you said.
There's no shot of yet. That's my concern, and he would have had a long trip, but for hematological, I don't recall we did the hematological work, to be honest.
It's gonna be repeated after, you know, like, if you suspect anticoagulation, you have to repeat that.
They fit it after a while, and
Yeah.
then it's get all the stuff.
Like,
You have to repeat it again, just to make sure.
Thank you.
Excellent,
Thank you so much. I hope I didn't bore you guys with the.
very nice case.
I will move.
Thank you so much for your case. We'll take 2 minutes or 5 minutes for people here. You can go get dinner. And we can set up the next one in 5 minutes.
Let her bring the food and come back.
Welcome back, everyone. We're excited to start our second case by Dr. Khalid Imam. He's going to be presenting an interesting complex CTO case. This mic. Close it for you. أي، كلنا.
Hello, everybody. Sam, do you hear us now? Online, Sam, or you say we don't hear you, Khalid. So, Assalamu alaikum. Check this.
Cheated questions.
First of all, Assalamu alaikum. I would like to thank and the group and Dr. Wael Kashkari, the classic group for a nice joint meetings. So my case today is a CTO, a little bit complex case. Let's say moderate case with complexity, but he has a lot of history. So it's a long case with a male 67 years old male patients known to be diabetic, hypertensive, ischemic heart disease. Actually, he has a multiple PCI to since 2000, before 2017, but I have the history from 2017. He has a multi-vessel disease, which is refusing to do a cabbage several times. So he went to several other hospitals, our hospital, military hospital, several hospitals. He get treated with a multi-vessel PCI, including 3 stents in the RCE, 2 stents in the RCE. Then he get a left main disease, LAD disease. He gets stented. Both. Then he gets symptom again. Then they found him. They find a mid segment LAD in central stenosis. They fix it, but they find the CTORC. Patients after the last angioplasty since 2019, he get class 2 to 3 angina, class 2 to 3 angina, and what's impressive was he had class 3 to 4, which was not improving by medical treatment. This guy, he was in the full anti-ischemic medication and failure medications, but he's every day sleeping as an orthostatic sitting. He don't sleep at night because of the dyspnea. He cannot speak. Recurrent admission to the hospital with heart failure symptoms, and then he get referred to us to just maybe if we open this CTO, patient will improve. We did for him an echo. Ejection fraction was not that top, it's 40 to 45. And we did for him viability by the vitamin stress echo. We saw that he has a viable infralateral wound. So this is the angio of these patients. He has a very nice left main LAD, and this mid segment LAD also stent is patent. And you can see a very big postlateral branch, which feeling good retrograde from the septal branch, but the problem, the septal has been gelled with 2 overlapping stents in the mid segment. This case was make it lively to Italy. So we was doing this case live case. And here is our RCO, CTO. It's an ostial instant occlusion, very long. He has a stent in the proximal segment, and then mid segment there is no long segment without stent, and then until the crux. They have here the CTO. So give you well, you saw the film. I saw the picture.
So here's the RCA CTO, long lesion with instant occlusion, which this has been filled before to attempt 2019 when they do the left main. Then they try second time because they do the left main and then instant restenosis in the mid segment, LAD. And then they find the CTO RCA and they failed to go from this stand at that time. So they remain the patient for medical treatment.
So 2-time antigrade failed.
No, one time antigrade failed.
Yeah.
One time antigrade failed, but this 2019 and this failed 2022. And patient has unexplainable to have this kind of chest pain and heart failure symptoms. I will just show you the quick view of 2017 before they put this stent in the left main. So how this vessel was looked like. So this 2019, actually I don't have any, I have only this picture. I don't have the angioplasty picture. So he has this very bad distal left main and mid-segment LAD, which has been treated very well. Nicely, it's patent. So they treat this one, LAD left main, mid-segment LAD, and then after 1 year, he get progressing of the lesion in the mid-segment LAD, which they will stented. 2017, he has this big RCA. Big one. And was patent. Then they opened for him. In this place, they said they refer him to cabbage. He refused cabbage. He went to other place, which they have expert operators. They did the left main, LAD, and then patient went fine for 1 year. 2018 has a mid-segment LAD progression. They put stent again, but they find they have a CTO on the RCA. Then they try, they fail, then put the patient in medical treatment. Patient is still symptomatic. So here, long segment calcified. If we go back to analyze this RCA, tortuous, long segment, calcified, failed trial. So this Japanese G score 4. So discussion here, what to do.
I think the easiest way, given that your retrograde channel is covered by the stents, is to knuckle and go down. And if it's dissect and it's parallel to the true lumen, re-enter there. Use the stingray re-enter. I think that would be the fastest and the easiest way to do this. So
Yeah.
ADR.
ADR.
Yeah.
But ADR is very long. The segment is very long. Yeah.
You just go down.
If we can, usually I don't like, I'm not the guy with the ADR, but usually it's a good option to have ADR. If you can go from this stand to down, that will be one of the options. The other options,
I will tell you the other option, I will send him to Khalid Tamam.
no, it's just luck to do it. So medical treatment has been failed. Angioplasty maybe changing from operator to other operator who's focused in the city, what maybe is good options. I send it to a car if it's me. If it's failed, I will send it to other hand. Retrograde is very good one, but in spite he has these two stent close the entry of the septal channel. So just to go quick, this algorithm has been done by Menos, which is all working with this algorithm now. And this is you should have the whole setup dual catheter injection, big catheter, good support, very good support. And if you have a big West cap, you should thinking about ADR or parallel wires, and you go with a step by step anti-grade. If it's failed, to go ADR. If it's failed, to go retrograde. And usually when we are, and if it's failed, we can go by ADR knuckling. And if the flow is not bad, is not good, we do as a replacement procedure, and then we can stop and go again, and maybe we find the track. But for me, I try to have a good setup with a 7 French guiding catheter, plus left, and I get a very heavy wires. I get a next 2, which was very good to penetrate, and then was not working well, and then I get a Confianza Pro 12. The problem here is it's going well to until here, and then going suboptimal. The tip of the wires, tip of the wire.
The difference between Gaia 2 next and Gaia 2.
The difference only with controls the tip of the wires, and the Gaia next families is the tip of the wire control is more better than the Gaia, the normal Gaia, and Gaia next 4, it's equivalent of Confianza and the Gaia next together. So he has a 2 function of the wires. You can rotate, you can, but still not approved here is not delivery here. But this is the best one for penetration. When we have an instant occlusion, don't go with wire escalations. You have to go with heavy wire directly, because the pathology inside the instant occlusion need always heavy wire. So you go with penetrating wire or Hornet, Confianza Pro 12, and it's not so penetrating, but it's controllable. So you need just to have escalation wire by good penetration wire, and then de-escalating with the other wire.
Which microcap?
Caravel. We need to have a good, with this one, I have 2 options. Caravel Pro, sorry, not Caravel, Corsair Pro, because Caravel cannot rotate, can be very easy to be rupture in this case. So I go with Corsair Pro, and if it's not go because of the calcification, I going with Thermopipe Gold, which can be easy to rotate to do now. So here is Corsair Pro with a Gaia Next. You see here, I'm outside. I'm trying to go again, but it all is outside.
Did you consider knuckling?
No, I'm not. With in this stage, knuckling is not good. So you can go to the mid segment, and if you are knuckling and the star in the RCA, it's the end. So if I'm doing retrograde, antigrade, retrograde, I can do knuckling, and then I finish with reverse card. But knuckling, that means I end the case. I'm still first 30 minutes. We continue 4 hours. Maybe after 6 hours I do knuckling, but not after 30 minutes. 30 minutes is just, we are just playing this. So it's here again, it's not in the full human. So here I redirect again, and here is already it's good in the full human. I get a different projection, and this was Confianza Pro 12. And here the Confianza already gets the job, so I have to de-escalate the wire. I used a Pilot 200 for my wires. If we in this stage we can knuckle if you are failed. If you fail to cross.
So you use dual camera height at the same time.
Yes, but this was in the live case. So live case I do a single play, but usually I'm using a double So here, I'm reaching distal good lumen with a pilot 200. But the surprise is not to pass the wire. We have a big surprise later. So I pass the wire, I change the wire, I try to rotate the microcaster to go down. So it's been no, it's not dissection, so I'm rotated, it's good with a Corsair Pro. So it means not the here is it's not in the also human, so the full human. I will confirm by IRIS. Here I have a TB injection. Usually I don't do it, but I'm distally through human. Then, as you see, just after passing the microcaster, I have some of the hematoma here. Maybe I'm the false through. False. I need to confirm by IRIS. So in this stage, I need to go with the BDA. So I put a WM microcaster, Suzuki. Just secure the BDA. This is small, but just to, as what I said, we love to have all the branches.
And you have to have guide size 12 bridge.
So I get a BDA as well with a WM microcaster. And then I get balloon. And what surprised me now, I get a very, you remember the left main, we don't see the circumflex.
Yeah.
And we have an angio 2017 with RCA. And now, after we open, I just pull back the catheter because it's have a very damping pressure after and then get balloon. And then I get a anomalous of the circumflex artery has been originated from the RCA disease. A disease and total occlusion. So I have another CTO. So what to do now? To open this CTO or to continue to zoom this one and then we continue with this one? So it has a big circumflex artery which has been anominated, originated from the, I don't know from where. And this has been stenting. So there is also stent disclosed this RCA.
This circuit.
Yeah, this circuit. Yeah, has been closed by stent. And if you see 2017, we have an angio, as you see this big RCA, no circumflex.
No, sir.
And we have not even retrograde feeling from this circumflex. So that's why the patient, I thought patient has a very large ischemia in the infralateral position. And yes, and the patient has a recurrent pulmonary edema and the heart failure. So probably because this circumflex.
I would really consider not to deal with this circ before I do the final in the RCA. Like at least I do proper injection to see how the circ, how it look like, what is the origin. Is it too big? So
Yeah, it's it was life. I have to finish the case. But anyway, I did this IVUS to make sure that this IVUS before seeing this circumflex. So you see all true human from distally to proximally. So we are true to true. It's very long IVUS run. And this is stent, you see it is very small. The artery is almost 4.5 or 50, and the stent is 3.5 or 30. 3.5 the stent, and the artery is huge, big artery. And you see, we are all true human, even the stand is true human, and this is the osteopathy. And you see here, we are go back. Yes, it's just playing inside our street.
So what do you think, most of the ISR is under expansion, not a position? Like here, your experience, the local experience, what do you think is the main cause of that?
50-50. ISR or undersigned.
Just a quick comment from the. We have Dr. Hassan Noor, who joined us, excited about the CTO case from an expert here. Gaia next series, he's just commenting on the Gaia. So he said Gaia next series better control, but doesn't get stuck or trapped in a calcified CTO. Has higher penetration power than CP12. Just a comment, so it seems like the stent already covered where the ostium of the circ is, right?
Yes,
So at this point, maybe just keep ballooning it and see.
but if I balloon more than this one, maybe I lose it again. So the chance before wiring the circumflex, we may use it, we may lose it. So what do you think, Wakar, in this case? You keep it until here and you start to deal with the circumflex?
I think I will take the right coronary, take care of it. I'm already there.
Yeah, and what about
And
circumflex?
then go after the circumflex, maybe at a different procedure. Depends how long you've been doing, how much contrast, how much radiation.
Yeah. So I think Hassan was asking the.
Yeah,
Dr. Hassan Noor, if you have, we're asking you what would be your next step at this point with the CERT having an anomalous takeoff from the RCA. So what would you do? Would you try to go after the CERC or finish what you have with the RCA? He said DLC and wires CERC.
Yes. Okay, so it's CTO guys always want to thinking the same. So I stand the mid segment RCA, just this area, which I think it was some dissected area, so I stand it. To secure the distal part. Oh. Okay, it's one. I try first to rewire the RCA, the circumflex, but I could not. Several times I could not. I could not wire it. So I fixed this mid segment RCA, and this was balloon. I tried to wire this circumflex.
that's light,
Yeah, and cannot wire.
maybe,
This is outside.
maybe later on, after you finish the RCA, you go back with a different catheter, probably this is not the best catheter to engage that.
Yeah, this may be. Yeah. We have a TIMI3 flow to RCA. We fix it, but still here it's very difficult to wire this R3, even with different wires.
Dr. Hassan is commenting saying using a ping pong cap.
Yeah, so maybe I would want.
Yeah, to keep the wire.
So what I did here, because I have a double macrocaster, so I tried to use it with a double macrocaster, and I get with a cyan black, which was able to cross this lesion. Yeah, but it's not now. I tried here, it's not working, and then I was afraid to lose this. You see here, several times could not pass, with several wires could not pass. And I was afraid with playing so much to lose it again, because you see here, is almost disappeared.
It could be that the
So
guy
I-
is deep too.
Yeah, so it's not, the guy is not deep, but I think it's, I play a lot, so I was afraid to dissect the osteum of circumflex, so you made easy to dissect it. So ping pong, as Hosam said, is a good option to get another short guiding, short tail guiding, put it there, and you just do it. Here with W macrocaster, I could not even pass. With several wire, with a pilot 200, I don't want to go with a Gaia in this case because I don't know where it's going. But I'm just try with hydrophilic wire. But this is always the case to dissect the host. So what to do here? Stand the RC and that's it. And give the patient another time without stenting the ostium. Leave the try again, because now we are achieved already 3 hours, 2 hours to finish.
It'd be like a case of investment when you do ballooning everywhere, then bring the patients. Yes.
Yeah, it can be, the only problem, I was afraid to lose this circumflex.
I would still deal, yeah, and just leave that segment where the circ is originating and bring him later on. That's I think very reasonable decision, and yes, as a live transmission, you want to show the people that the wonderful result, but this is, I think, will be an exceptional good result. You leave that ostium for later on to deal with that circ.
That's what I did, but I just stent the mid segment with 4.0 and then 4.5. And I left this segment, but I belong, I could not leave it there open it. So I get again. So you just open the RCA, you get the deep breath and you start again.
Were you still live
Yeah, we're still live.
on the live case?
Yes, we still live. Yes.
Live or alive?
No, we both patient even
No,
unless the patient is deteriorate or has a back pain or he cannot, or I exceed the radiation dose or I exceed the contrast dose, then we continue. So if this 3 is not there, so you can go.
that's amazing.
So I went there, I changed my microcaster to crochet again. Then I get the wire inside the RCA with the XTR. And then I'm there. I get it. I just direct the microcaster outside and I engage the microcaster to the circle, probably. So here, if you can go with this view to ariocranial, then you just deeply engage to the circumflex. And then I get the caudal view, which I'm truly in the circumflex by caudal.
Do you think this is a CTO or just because of the CTO of the RCA, this makes a soft glider?
I think it's CTO as well, because we have an angio 2017, nothing. Yeah, and then we have a 3 angio after that, nothing at all. And all by old operators. So it's
But to me, it looks like there maybe separate ostia, maybe
yeah, separate ostium, but the black it's a little bit soft than the other one. It's not harder than the RCA. Because RCA is stand inside, the de novo black.
maybe in 2017 we were deep in the RCA units.
We'll see it again. We'll go again to 2017 and we'll see how it was. Then I stented, I balloon. Then we try to do tap.
Do you have a wire in the RCA?
Yes, wire, balloon,
Oh, I.
yeah. I get IBUS also on the circumflex. Final kissing, and then I did both. And this RCA circumflex also as well.
Amazing.
Yes, thank you. This is the final result. Very big, and the patient still follow up with me last week, and he's doing great. Or chest pain, no sign, no symptom of heart failure anymore. I get him today. He get a echo, which was improving the ejection fraction from 40 to 55. Still some wall motion abnormalities in the inferior, but it's very small one. But it's asymptomatic. So my take home message, conclusion, escalation is always followed by de-escalation. It's very important to have a soft tip, torqueable guide wires to advance through the area of resistance. Always by doing these techniques, which has been mentioned by Manos Belakis and our groups in progress, we get successful by de-escalation and escalation, or different by escalation and de-escalation. By anti-grid approach can be achieved 80 to 85% of success rate. If the anti-grid failed, again, still you can recross by parallel techniques, re-entry techniques, or retrograde by septal or epicardial. Thank you very much.
Amazing, this.
This is jackpot case. Really wonderful. It's a very nice conclusion. The case nicely done. Very complex. You made it. I'm sure it was very tough on his life, but I wish if I was there to watch this case live. It's a very exciting case. Very well done. This anomalous circ per se, it make the case live nightmare, but it managed very well. Waqar?
Yeah, excellent result.
Hussam Noor, he can comment, by the way, vocally.
Yeah, congratulations, excellent result finding the circumflex. That was very fortuitous.
I will show you again
Just question,
you see here the RCA 2017. Even this junk, it's not you cannot see the circumflex at all.
Hello?
Again,
Why?
Flow back crunch, you cannot see it. And if you go by this different view, حتى ما فيش easy, and nobody can think this as an anomalous of the RCA. And here, when they do this, they think this is small, the circumflex. They say because the RCA is huge dominant RCA. So now nobody will think that they have an anomalous RCA with this anomalous circumflex with this RCA1.
Yeah, the mic, you can tell.
You see, I would say that's circ. I will never think there is an anomalous circ. There is some branches coming. I would say this is definitely circ in the presence of that huge RCA. I would not really think about the anomalous circ.
Dr. Hussam Noor, you're still with us. We just want to hear your comments, questions. You can unmute yourself.
Assalamu alaikum, everyone. How are you, Rasha, Wael, and all my friends and colleagues there? It's a great pleasure to be part of this, and I'm really enjoying these two cases. Mu'tasim's case was fantastic. And of course, I get very excited when I see the CTO cases, and Khalid did really a MAGA, which I call Make Arteries Great Again. It's an amazing case, well done, and the discussion has been very fruitful. And I think the case that Khalid showed, it also gives us the opportunity to discuss sometimes. I mean, it's very ambiguous whether you have a circ or not in these images, but occasionally, especially if a case was failed once or twice, in my practice, I typically do a CT, in which because these are elective cases, then at least one, I would know the course of the artery better. Two, if there are anything like this, which is a circ, which is fantastically short at the end, would also make my life a little bit easier going through this very, very complex case that Khalid demonstrated excellent skills and procedure steps, step by step, to have the artery great again. Thank you again, and really fantastic.
Thank you, Sam. I think it's, your comment is valid. It's, but with I tried to do CT for this case, but he has a 12 stent. So I could not. He told me before I have a 12 stent. So I said sit for the CT guy. He told me we could not see anything. We just see a lot of stents there. It's yes, it's if the patient has not many metal jacket stent, I will do the CT scan to see where is our cost. We do that as routine, but again, a lot of radiations, patient will pay the radiation and the extra amount of contrast, but it's very wide.
What is going to be your next strategy? Anti-grade virus patient fail.
So that's really. Yeah, I will go maybe Osam is and Wakar, he has also the same with me to do. I will go with a stand. I will go with a wire. Try to enter from the stand. No microcatheter will pass. So 1 0 balloon will open a small strut of the stand, and then you get the most low profile microcatheter like Carbon, one of the options, Crosea Pro XS, one of the other option, or Thermobike LV also, or the best one of them, it's you can go, it's not stable, the Fine Cross from Tron. And then after you pass with a microcatheter, you have to, after you finish, you have to again do post stand or port to the stand because you already destroyed the stand. But usually, if we have a two stand overlapping, it will be adding 1 hour more to go. Sometimes going easy, but sometimes you go from under the struts of these two overlapping, and your microcatheter is stuck. If this happens, you post, you either sit, you post stand dilate with maybe the artery is small, you go with a 4-0 balloon, so you post stand good, and then you try to wire it with a hydrophilic wire, and then you start to have a surfing of this.
If anybody in the online joining us and have any comments or questions, please let us know. We're going to be closing soon. Any comments from the audience about this case? Yes, go ahead.
Thank you so much. Very nice piece. I enjoyed the revascularization, but actually for innovation during angiography, if you will see the left circumflex territories in the left system during left coronary angiography, it's a very small or non-dominant, or like the case you present. I think it's better during angiography to disengage the right coronary catheter to see if there is abnormal course or not. Definitely, it will not change the revascularization option. But I think if we demonstrated anomalous origin of left circumflex from the right valve, so the intervention, it will be easy, like doing an PCI to the LAD in 2 segments, and the proximal and the mid segment. And during the intervention of the right coronary artery, as you did, it's an excellent job, but it will not change the strategy for revascularization. The only change in the decision is documented, so you will do only angioplasty instead of the LAD, not left main. So this is not left main intervention, and I think it's an proximal and mid segment LAD and right coronary.
I have the case at the end. This is 3 years and it's not mine, but I was not even when doing my calculate was just to do the RCA. I never thought that he had an anomalous of the circumflex. Even I review all the angio proximal of previous expert operators has been done. This all angio. I was not so. Even me as I think also they are also the best.
I think this is a nice case where a CT higher.
Yes, of course. Of course.
Excellent case, honestly. Very great discussion. I'm pretty sure all of us have learned something from both cases. Very complex and amazing results with both. We're just gonna be closing soon, because I just have a few comments.
I would like to thank everybody for the presence today, the audience physically and the virtually. I would like to thank the speaker, Dr. Khalid Tamam and Dr. Mafasl Tarabulsi for their generous time. Special thanks to Dr. Rasha Bawardi, the head of the scientific committee for the National Interventional Cardiology Club. This is a project by National Heart Center and the Saudi Arabian Society of Interventional Cardiology. We started there, and of course, the EPIC in the East region is the well-established one so far and the biggest one. So we are distributing these chapters to different regions. This program is led by Dr. Rasha and Dr. Saleh Ashlash from Riyadh. So the next step will be Medina, inshallah, with their cardiology club, and then we'll move to Riyadh. And I think it will be very exciting because there is too many large groups and different centers there, and we'll move to South. All of them, they will be hybrid, virtual for the people not able to attend locally. And the comment also will be the virtual, the people in the virtual can comment by writing. And as you hear, Dr. Hussam Noor, well-known, well-rounded intervention cardiologist in Bahrain, kindly, he was with us from Bahrain with excellent comment. Thank you very much once again, and we'll see you soon.